Your bones are weakening right now, not from trauma, not from a diagnosed skeletal disorder, but from a gradual process that began years ago and has been progressing silently while you went about your daily life completely unaware. That weakening is happening in the trabecular bone inside your vertebrae, where the microscopic lattice structure is becoming thinner and more porous with each passing year. It is happening in the cortical bone of your femur and radius, where bone mineral density is declining while the outer shell becomes more brittle and susceptible to fracture, from forces that would have been harmless in your younger years. It is happening in your hips, your wrists, your spine, in every bone of your skeleton simultaneously, creating progressive skeletal fragility that will eventually manifest as fractures from minimal trauma, compression fractures in your spine, causing height loss and chronic pain, or a hip fracture that fundamentally alters your independence and mortality risk. Bone health is not just about preventing broken bones in old age. It is about maintaining the structural foundation that supports every physical activity you perform, protects your internal organs, serves as the reservoir for calcium and phosphorus that regulate countless metabolic processes, and determines whether you maintain upright posture and independent mobility throughout your 70s and 80s or experience progressive disability from fractures and skeletal deformity. Osteoporosis is the most common metabolic bone disease in developed countries, affecting approximately 1 in 3 women and 1 in 5 men over the age of 50. It does not announce itself with pain or visible deformity until fractures occur, which is why it has been called the silent disease. Usually progressing for 10 to 20 years before the first fracture signals that bone density has fallen to critically low levels. The problem is that for decades we have treated osteoporosis as an inevitable consequence of aging, particularly for postmenopausal women, and focus medical attention on treating fractures after they occur rather than preventing the bone loss that makes fractures inevitable. What we now understand from bone biology research and intervention trials is that osteoporosis is not an unavoidable part of aging, but a disease process driven by modifiable factors including inadequate calcium and vitamin D intake, insufficient weight-bearing exercise, hormonal changes that can be partially offset, chronic inflammation, and various medications and medical conditions that accelerate bone loss. The bone density you have in your 70s and 80s is determined largely by the peak bone mass you achieved in your 20s and 30s, and the rate of bone loss you experienced in the intervening decades, both of which are influenced substantially by lifestyle factors under your control. Most people have been losing bone density for years without knowing it, without having it measured, and without implementing the interventions that could have prevented the progression from normal bone density to osteopenia to osteoporosis and eventual fractures. Hi, I am Dr. Alex. I am an emergency medicine doctor, and after nearly 10 years in emergency departments, I have seen what happens when osteoporosis, that could have been prevented or treated early, presents as devastating hip fractures in elderly patients who lose their independence and face dramatically increased mortality risk in the year following fracture. I have seen vertebral compression fractures causing chronic debilitating pain that severely limits quality of life. I have seen the cascade of complications that follows immobilization from osteoporotic fractures, including pneumonia, pressure ulcers, and deep vein thrombosis. And my goal now is to help people understand what osteoporosis is and why it matters when bone loss actually begins and how rapidly it progresses, and what interventions are proven effective at preventing bone loss or rebuilding bone density before fractures occur. For the next several minutes, I want to walk you through the biology of bone remodeling and how it changes with age, explain why standard screening often misses early bone loss, and provide evidence-based strategies for optimizing bone health throughout your adult years. Okay, so if you are watching this video, you are probably concerned about bone health and fracture risk as you age. And I just want to take a moment here to make you a promise. I promise to keep creating the most helpful, evidence-based videos I possibly can, grounded in clinical research and the latest science on bone health and healthy aging, to help you maintain skeletal integrity and prevent the fractures that rob independence. And all I ask in return is that you give this fairly new channel a chance and hit the subscribe button. If you get to the end of this video and you did not think it was worth your time, or you have not learned something genuinely useful about protecting your bones, then feel free to unsubscribe. No hard feelings at all. But if you give me your time and attention, I will give you everything I have learned from over a decade in medicine and extensive reading of bone health research. So please help me out, hit the subscribe button to help this channel reach more people like you, and let us continue with the video, how bone remodeling works and why it fails. To understand osteoporosis, you need to understand that bone is living tissue that is constantly being broken down and rebuilt through a process called remodeling. Specialized cells called osteoclasts resorb old or damaged bone, creating small cavities in the bone matrix. Other cells called osteoblasts then fill these cavities with new bone tissue that mineralizes over several months to restore structural integrity. In healthy young adults, the activities of osteoclasts and osteoblasts are perfectly balanced, meaning that the amount of bone removed equals the amount of new bone formed, and total bone mass remains stable. This remodeling process is essential because it allows bones to repair micro-damage from daily mechanical stress, to reshape in response to changing loads, and to serve as a reservoir for calcium that can be mobilized when blood calcium levels fall. Peak bone mass is achieved in the late 20s to early 30s, after which the balance begins to shift. Research published in the Journal of Bone and Mineral Research has documented that starting around age 35 to 40, bone resorption begins to exceed bone formation, meaning that each remodeling cycle results in a small net loss of bone tissue. This imbalance is modest initially, approximately 0.3 to 0.5% loss of total bone mass per year in both men and women. However, the rate accelerates dramatically in women at menopause when the protective effects of estrogen on bone are suddenly lost. During the first 5 to 7 years after menopause, bone loss can reach 2 to 3% per year, particularly in trabecular bone, which is more metabolically active and more responsive to hormonal changes than cortical bone. This accelerated postmenopausal bone loss is the primary reason osteoporosis is more common in women than men, though men experience progressive bone loss as well, driven by age-related declines in testosterone and growth hormone. The mechanisms driving the shift from balance remodeling to net bone loss are multifactorial. Estrogen deficiency at menopause removes direct inhibitory effects on osteoclast activity and reduces osteoblast function, tipping the balance toward increased resorption and decreased formation. Age-related declines in growth hormone and IGF-1 reduce osteoblast proliferation and activity. Chronic low-grade inflammation that increases with aging elevates cytokines that stimulate osteoclast activity. Reduced physical activity decreases the mechanical loading that stimulates bone formation. Inadequate calcium and vitamin D intake limits the raw materials available for bone mineralization. Secondary hyperparathyroidism from vitamin D deficiency or age-related decreases in calcium absorption increases bone turnover with net bone loss. Each of these mechanisms operates simultaneously in most individuals over 50, creating cumulative bone loss that accelerates over time and eventually crosses thresholds where fracture risk increases exponentially. When screening happens and what it misses, current screening guidelines recommend bone density testing for women at age 65 and for men at age 70 or earlier if risk factors are present. Bone mineral density is measured using dual energy X-ray absorptiometry known as DEXA scanning, which provides a T-score comparing an individual's bone density to the average peak bone mass of a healthy young adult. A T-score above -1 is considered normal. A T-score between -1 and -2.5 indicates osteopenia, which is low bone mass that does not yet meet criteria for osteoporosis. A T-score at or below -2.5 defines osteoporosis. These thresholds were established based on fracture risk data, showing that each standard deviation decrease in bone density approximately doubles fracture risk. The problem with waiting until age 65 or 70 for initial screening is that it misses decades of bone loss, during which intervention would be most effective. A woman who loses 2% of bone mass per year for 5 years after menopause at age 50 has lost 10% of her bone density by age 55. potentially dropping from normal to osteopenia during a period when no screening occurred. By age 65, when screening finally happens, she may have osteoporosis requiring medication rather than osteopenia that could have been managed with lifestyle interventions alone. Research in Osteoporosis International has demonstrated that earlier screening, particularly in the perimenopausal and early postmenopausal period for women, and starting at age 50 to 60 for men with risk factors, identifies bone loss at stages when less intensive intervention can prevent progression to osteoporosis. Additionally, DEXA screening provides only a snapshot of bone density at one moment in time. It does not reveal whether bone density is stable, declining slowly, or declining rapidly. Serial DEXA scans, separated by 1 to 2 years, can assess the rate of change, but this is rarely done unless a patient is on treatment for osteoporosis. Biochemical markers of bone turnover, including serum C-telopeptide measuring bone resorption and serum procollagen type 1, N-terminal propeptide measuring bone formation, can provide information about the dynamic state of bone remodeling, but are not routinely measured in clinical practice. The result is that most people have no idea whether they are losing bone rapidly or slowly until they either undergo DEXA scanning, which may not occur until bone loss is already advanced, or experience a fracture that signals critically low bone density. What actually prevents and reverses bone loss? The most powerful intervention for bone health is weight-bearing and resistance exercise that creates mechanical loading sufficient to stimulate bone formation. Bone responds to mechanical stress by increasing density and strength in the regions experiencing the greatest loads. Walking is weight-bearing but creates relatively modest loads that are insufficient to maintain bone density in most individuals. High-impact activities like jumping, running, and sports involving rapid changes of direction create higher loads and produce greater osteogenic stimulus. Resistance training with weights or resistance bands creates very high localized forces on bones where muscles attach, stimulating bone formation at those sites. Research in the Journal of Bone and Mineral Research has demonstrated that postmenopausal women who engage in progressive resistance training combined with high-impact exercise maintain or increase bone density at the spine and hip, while sedentary controls lose bone density at rates of 1 to 2% per year. The exercise prescription for bone health is more specific than general activity recommendations. For the spine, exercises that load the vertebrae through compression or extension are needed, including activities like jumping, weighted squats, and deadlifts. For the hips, weight-bearing activities that create impact forces such as walking with weighted vest, jogging, or jumping exercises are most effective. For the wrists, weight-bearing on the hands during push-ups or similar exercises provides targeted loading. The intensity needs to be sufficient to create loads that exceed what the bones experience during normal daily activities. Research suggests that the minimum effective dose is 2 to 3 sessions per week of combined resistance and impact training, with each session including exercises targeting the spine and upper body. Studies have shown that this level of exercise can increase bone density by 1 to 3% per year in postmenopausal women, effectively reversing the natural rate of bone loss. The second essential intervention is ensuring adequate calcium and vitamin D intake. Calcium is the primary mineral component of bone, and inadequate intake forces the body to mobilize calcium from the skeleton to maintain blood calcium levels, creating net bone loss. The recommended intake is 1,000 to 1,200 milligrams per day for adults over 50, ideally from dietary sources including dairy products, leafy green vegetables, and fortified food, with supplementation. If dietary intake is insufficient, vitamin D is required for calcium absorption in the intestine and for normal bone mineralization. Vitamin D deficiency is extremely common, affecting an estimated 40 to 60% of adults over 50, and leads to secondary hyperparathyroidism that increases bone turnover and accelerates bone loss. Research in the New England Journal of Medicine has shown that vitamin D supplementation to achieve blood levels of 30 to 40 nanograms per milliliter reduces fracture risk, particularly when combined with adequate calcium intake. The third intervention is addressing modifiable risk factors that accelerate bone loss. Smoking increases bone loss through multiple mechanisms, including reduced estrogen levels in women, increased oxidative stress, and impaired calcium absorption. Excessive alcohol consumption, defined as more than 2 drinks per day, impairs osteoblast function and increases fracture risk independent of effects on bone density. Certain medications, including glucocorticoids, proton pump inhibitors used chronically, some antidepressants, and anticonvulsants, accelerate bone loss and should be used at the lowest effective doses for the shortest necessary duration, with bone density monitoring when long-term use is required. Maintaining healthy body weight is important because being underweight significantly increases fracture risk, while obesity provides some protection through increased mechanical loading and higher estrogen levels from adipose tissue aromatization. The fourth intervention for individuals who have already developed osteoporosis or who are at very high fracture risk is pharmacological therapy with medications that either inhibit bone resorption or stimulate bone formation. Bisphosphonates, including alendronate and risdronate, inhibit osteoclast activity and can increase bone density by 5 to 10% over 3 years of treatment, with corresponding reductions in fracture risk. Denosumab is a monoclonal antibody that inhibits osteoclast formation and function, producing similar or greater bone density increases. Teriparatide and abaloparatide are anabolic agents that stimulate bone formation and can produce larger increases in bone density than anti-resorptive agents. The decision to use medication should be based on DEXA results, fracture history, and fracture risk assessment tools like FRAX that integrate multiple risk factors to estimate 10-year fracture probability. Medication is generally recommended when T-scores reach negative 2.5 or lower, when fragility fractures have occurred, or when 10-year fracture probability exceeds certain thresholds, even if bone density is not yet in the osteoporotic range. And here is what you need to understand. Bone loss is not an inevitable part of aging that you must accept passively. It is a disease process driven by identifiable mechanisms that can be substantially modified through exercise, nutrition, lifestyle factors, and when necessary, medication. The bone density you will have in your 70s and 80s, and therefore your fracture risk and likelihood of maintaining independence, is being determined right now by the choices you make about physical activity, calcium and vitamin D intake, and the other factors affecting bone metabolism. You were likely never told that bone loss begins in your 30s and 40s, that standard screening occurs too late to catch early bone loss, or that specific types of exercise are required to maintain bone density. But now that you understand these principles, you have the opportunity to implement interventions that can prevent osteoporosis or slow its progression while you still have time to make a meaningful difference in your skeletal health and fracture risk. What I see in emergency medicine. In emergency departments, we see osteoporosis in its most devastating manifestation, which is hip fracture in elderly patients. A simple fall from standing height, which would cause at most a bruise in a younger person with normal bone density, results in a fractured femoral neck or intertrochanteric fracture that requires surgical repair and creates a cascade of complications. The statistics are sobering. Approximately 20% of patients who sustain a hip fracture die within 1 year, often from complications of immobility, including pneumonia, pulmonary embolism, and sepsis. Approximately half of those who survive never return to their previous level of independence, requiring assisted living or nursing home placement. The hip fracture is not just a broken bone. It is a sentinel event that marks the transition from independence to dependence, from active life to disability, and often from community living to institutional care. What becomes painfully evident when reviewing the medical histories of patients presenting with osteoporotic fractures is that the bone loss was progressive and detectable for years before the fracture occurred. Many had known osteopenia or osteoporosis on prior DEXA scans, but were not treated aggressively or did not adhere to recommended interventions. Some had never been screened despite being in the recommended age range and having risk factors. Almost none had engaged in the type of high-impact and resistance exercise that research shows can maintain or build bone density. The fracture was not a random event or bad luck. It was the predictable consequence of decades of untreated or inadequately treated bone loss finally reaching a critical threshold where normal activities became dangerous. The patients who avoid osteoporotic fractures are disproportionately those who maintained bone density through consistent weight-bearing and resistance exercise starting in middle age, ensured adequate calcium and vitamin D intake throughout adulthood, avoided or minimized bone-damaging behaviors like smoking and excessive alcohol use, and when appropriate, initiated pharmacological therapy before fractures occurred. These individuals often have DEXA scans showing osteopenia rather than osteoporosis in their 70s and 80s, or normal bone density if they engage in optimal bone-loading activities throughout their adult years. They maintain the skeletal strength necessary to withstand falls and impacts that would fracture osteoporotic bones, preserving independence and quality of life that is lost to those who experience fractures. The bigger picture is that osteoporosis and the fractures it causes are largely preventable. The disease is silent but not invisible. It can be detected through bone density screening years before fractures occur. It can be prevented through exercise that creates appropriate mechanical loading, adequate calcium and vitamin D intake, avoidance of bone-damaging behaviors, and when necessary pharmacological intervention. The tragedy is that most people do not learn about osteoporosis until after they have developed it. Do not understand that exercise must include high impact and resistance components to benefit bones, and do not implement preventive measures during the decades when prevention is most effective. The information exists, the interventions work. What has been missing is awareness that osteoporosis is not inevitable, that it begins earlier than most people realize, and that specific actions can prevent the progression from normal bone density to osteopenia to osteoporosis and fractures. So here is what I want you to take away from this. If you are over 40, you are likely experiencing bone loss right now. The rate of that loss depends on factors including your sex, menopausal status if female, activity level, calcium and vitamin D intake, and various other risk factors. You can assess your current bone density through DEXA scanning, which is recommended earlier than age 65 for women or 70 for men if you have risk factors including family history, prior fracture from minimal trauma, chronic steroid use or early menopause. You can substantially slow or reverse bone loss through progressive resistance training and high-impact exercise 2 to 3 times per week, targeting the spine, hips, and upper body. You should ensure calcium intake of 1,000 to 1,200 milligrams daily and vitamin D supplementation to achieve blood levels of 30 to 40 nanograms per milliliter. You should avoid smoking, limit alcohol to moderate levels, and discuss bone health implications of any long-term medications with your physician. If DEXA reveals osteopenia or osteoporosis, you should implement intensive lifestyle interventions and discuss pharmacological therapy with your doctor based on your fracture risk. These actions are not optional wellness practices. They are evidence-based medical interventions that determine whether you maintain skeletal integrity and physical independence throughout your later years, or experience fractures that fundamentally alter your quality of life and survival. And finally, please subscribe to the channel if you found this video useful. It helps me reach more people trying to protect their bone health and prevent the fractures that rob independence and quality of life. Thank you for watching.